This is a review of Chapter 16. To begin, I want to talk about the differences between the somatic nervous system and the autonomic nervous system. First of all, both of these systems send out motor commands, so they're both part of the motor division. What that means is, here's your brain, there's your spinal cord. Both of these divisions are going to send motor commands out to an effector. So there's a neuron that in synapses with another neuron, and that other neuron goes out to an effector. The neuron that's completely encased within the central nervous system, we know the central nervous system is the brain and the spinal cord. That's called the upper motor neuron. And the neuron that starts in the central nervous system but extends out to an effector, that is your lower motor neuron. The effector, in the case of the somatic nervous system, is skeletal muscle. So if this is the somatic nervous system, the effector out here is skeletal muscle. For the autonomic nervous system, the effector is going to be glands, cardiac muscle, smooth muscle, and adipose tissue. With the somatic nervous system, there is one upper motor neuron and one lower motor neuron. For the autonomic nervous system, there is one upper motor neuron and there are two lower motor neurons. So if we look at this picture that I drew over here, this would be your somatic nervous system. There is one upper motor neuron, and that synapses onto a lower motor neuron, and that lower motor neuron goes to the sends action potentials to the effector, and the effector is skeletal muscle. Now if we look at the autonomic nervous system, there's the brain, there's the spinal cord, here is the upper motor neuron, and it synapses onto a lower motor neuron, but this lower motor neuron will synapse onto another lower motor neuron. The first of these is called the preganglionic neuron, and the second neuron is called the postganglionic neuron. So that's another difference between the two. Then if we look at the neurotransmitters, we'll see that in the somatic nervous system, that lower motor neuron releases acetylcholine, ACH, and acetylcholine binds to the skeletal muscle. So the neurotransmitter for the somatic nervous system is ACH. In the autonomic nervous system, the preganglionic neuron releases ACH, and the postganglionic neuron will either release ACH or it will release norepinephrine. It releases ACH if it is part of the parasympathetic nervous system. It releases norepinephrine if it's part of the sympathetic nervous system. There's one example that I want you to know, but we'll talk about that later. So for the autonomic nervous system, the neurotransmitters are ACH and norepinephrine. Another neurotransmitter in the autonomic nervous system is epinephrine, but that's another exception that I'll talk about later. Another difference between the two is that in the somatic nervous system, when ACH binds to the skeletal muscle, it's always excitatory, meaning if it binds, that skeletal muscle will contract. So it's always excitatory. With the autonomic nervous system, when acetylcholine is released, or if norepinephrine is released, it is sometimes excitatory and it is sometimes inhibitory. And that depends on what receptor ACH or norepinephrine binds to. So we'll discuss that as well. Excitatory in the autonomic nervous system would mean that the smooth muscle would contract or the cardiac muscle would contract. That would be excitatory. Or it would mean that if it were inhibitory, then those muscles would relax, and that would be inhibitory. Or if we're talking about glands, if it's excitatory, then those glands would secrete. And if it's inhibitory, if the response is inhibitory, then those glands would not secrete. So that's the difference between the somatic nervous system and the autonomic nervous system. And Chapter 16 is really dealing with the autonomic nervous system. So what we're going to do is look at the autonomic nervous system. The autonomic nervous system has two divisions, the sympathetic division and the parasympathetic division. So sometimes we call it the sympathetic nervous system and the parasympathetic nervous system. Let's start by looking at the sympathetic division, or the sympathetic nervous system. The sympathetic nervous system has two lower motor neurons. So first of all, we're talking about the autonomic nervous system. And the autonomic nervous system, the upper motor neuron is always going to start in the hypothalamus. So here's the upper motor neuron. And then the lower motor neuron is going to exit. There's many lower motor neurons, but they're going to exit somewhere between T1 to L2. So that's the only area really that the lower motor neuron can exit from in the sympathetic nervous system. So the sympathetic nervous system has two neurons. It has the preganglionic neuron, which is right here, and then it has the postganglionic neuron, which is right here. The preganglionic neuron is always short, and the postganglionic neuron is always long. The postganglionic neuron, which is this one right here, will end at an effector. And the effector will be either the cardiac muscle, smooth muscle, adipose tissue, or glands. Now let's look at the neurotransmitters. With the sympathetic nervous system, the preganglionic neuron will release acetylcholine. Acetylcholine then stimulates the postganglionic neuron, and then the postganglionic neuron releases the neurotransmitter norepinephrine. Norepinephrine then binds to each of these effectors. Sometimes norepinephrine stimulates these effectors, and sometimes norepinephrine inhibits these effectors. And this is going to be dependent on what type of receptor is on these effectors. There are four main receptors on these effectors. There's alpha 1, alpha 2, beta 1, and beta 2. Alpha 1 and beta 1 are always stimulatory. Alpha 2 and beta 2 are always inhibitory. So if norepinephrine binds to an alpha-1 receptor, it will stimulate a response from that effector. If norepinephrine binds to a beta-2 receptor, it will be inhibitory and will stop that effector from producing an action. So let's give a couple of examples. Alpha-1, this receptor is found on two places that I'd really like you to remember. One is the pupil dilator muscle, and the other is on peripheral blood vessels. So if norepinephrine is released from that postganglionic neuron and it binds to the pupil dilator muscle, and if you remember the pupil, so here's the pupil, here's the dilator muscles, and then these are the constrictor muscles. So if norepinephrine binds to the dilator muscles and these muscles contract, it's going to pull these muscles out, and then the muscle will dilate. So it's stimulatory. It causes those smooth muscles to contract and dilate that pupil. If norepinephrine is released and it binds to the smooth muscles of a peripheral blood vessel, now remember these are all lined by a simple squamous cell. So we have all of these simple squamous muscles, smooth muscles, and if norepinephrine binds to those, it'll cause those muscles to contract. Those muscles are going to squeeze on that blood vessel, and it's going to cause vasoconstriction. Those are two very common areas where an alpha-1 receptor is found. So the smooth muscle has an alpha-1 receptor, and the dilator muscle of the pupil has an alpha-1 receptor. When they bind, it's stimulatory. Alpha-1 is a stimulatory receptor, and those smooth muscles contract, causing pupil dilation, as well as vasoconstriction of the blood vessel. And vasoconstriction of a blood vessel will increase blood pressure. Now let's look at beta-1, because beta-1 is also stimulatory. So beta-1, think of the 1 in beta. The heart, there's only one heart, so we'll think of the heart as having the beta-1 receptor. So we have a beta-1 receptor on the heart, and if norepinephrine is released and binds to that beta-1 receptor on the heart, it's going to cause the heart to increase. So we get an increase in heart rate, and we'll get an increase in contractility, which means the heart's going to beat stronger. So it beats stronger and it beats faster. So that's one area that I want you to remember, that the beta-1 receptor is on the heart. Then we have the inhibitory, beta-2 and alpha-2. So beta-2 is going to be found, that receptor will be found on the lungs. In particular, it's found in the airways of the lungs. So there's a beta-2 receptor on those airways, and if norepinephrine binds to those beta-2 receptors, the smooth muscle that lines those airways will relax, because beta-2 is inhibitory. So if they relax, what's going to happen to those airways? Those airways will dilate. So your airways dilate, and that allows more air down into your lungs. And finally, we have alpha-2, which is inhibitory. Now, alpha-2 is not found on an effector. Instead, alpha-2 is found on the postganglionic terminal. That's where the alpha-2 receptor is found. So norepinephrine binds to that receptor, and it will inhibit the release of more epinephrine. So the postganglionic neuron will stop releasing norepinephrine. So if norepinephrine doesn't get released, that is inhibiting all of these effectors. Now let's look at two exceptions that we have in the sympathetic nervous system. One exception are the sweat glands. With the sweat glands, so here's the brain and the spinal cord again. Here's that upper motor neuron coming down from the hypothalamus. Here's the preganglionic neuron exiting. And then here's the postganglionic neuron, and that neuron is going to the sweat gland. The preganglionic neuron always releases acetylcholine, and this synapse right here always occurs at what we call a ganglion. The exception here is that the postganglionic neuron also releases acetylcholine, and it binds to a receptor called the muscarinic receptor on the sweat gland. So that's an exception. Norepinephrine isn't being released. Instead, acetylcholine is being released. There's another one that I want you to remember, and that's the adrenal medulla. In this case, instead of having a preganglionic and a postganglionic neuron, instead, the preganglionic neuron extends all the way out to the adrenal gland, and in particular, the adrenal medulla. And in the adrenal medulla, then it stimulates the adrenal medulla, which acts as a postganglionic neuron, which will then release norepinephrine. It will also release epinephrine. Norepinephrine and epinephrine together are called adrenaline. So whenever a receptor releases norepinephrine and epinephrine, we call that an adrenergic synapse. And those neurotransmitters are known as adrenergic neurotransmitters. Acetylcholine, on the other hand, when that is released, that is called a cholinergic synapse. And acetylcholine is a cholinergic neurotransmitter. So acetylcholine has choline in it, so that's a cholinergic receptor, whereas norepinephrine and epinephrine, which are adrenaline basically, have adren in their name, so they're adrenergic. Now, we don't want to lose track of the overall big picture with the sympathetic nervous system. This is your fight or flight division. So whenever the sympathetic nervous system is stimulated, you're going to get symptoms of fight or flight. And if we look at some of these common effectors, like the pupils, think about, if you see a bear or if you get really scared, what's going to happen to your pupils? Your pupils will dilate. What's going to happen to your heart? Your heart is going to beat faster and beat stronger. What's going to happen to your respiratory system? Your bronchioles will dilate. And you start breathing in more oxygen. What's going to happen to your salivary glands? Well, when you're really scared, like think about standing up and talking in front of a large group. If you get nervous doing that, your salivary glands are going to dry up. So this is going to be inhibited. And inhibited means that you will have a dry mouth because you won't have saliva being secreted. Also in the GI tract, that's going to slow down. So you won't have as much, you'll have decreased mucus production and decreased motility. And in the urinary system, you'll have decreased urine production. You'll have the urinary sphincters will be stimulated though, because they'll contract so that you don't urinate. The sphincter muscles hold things in, hold the urine in. In the GI tract too, the sphincters of the rectum will hold the feces in, so you're not going to have defecation, so you'll have a decrease in defecation. Your blood vessels, at least your peripheral blood vessels, will constrict. And because your blood vessels are constricting, you'll end up getting increased blood pressure. You know, if a blood vessel has this much blood in it and then all of a sudden it constricts and gets more narrow, then your blood pressure will increase. And your erector pili muscles will contract. So you end up getting goosebumps. And then finally, in the reproductive system, when the sympathetic nervous system is stimulated, smooth muscles contract, and there's an orgasm, and there is also ejaculation. Now let's look at the parasympathetic division. So the parasympathetic division. All right, so there's the brain, there's the spinal cord. The parasympathetic division also begins in the hypothalamus, but the lower motor neurons are going to exit from different places. So the lower motor neurons will exit from cranial nerves. And specifically, there's 4 cranial nerves 3, 7, 9, and 10. So that's oculomotor, which is 3, facial, which is 7, glossopharyngeal, which is 9, and vagus, which is 10. The vagus nerve is going to carry 75% of all the parasympathetic motor commands. We also have sympathetic neurons extending from the sacral nerves. So in this case, the upper motor neuron extends down to the sacral area, and the preganglionic neuron will then extend from sacral nerves, and specifically S2 through S4. These preganglionic neurons are long, and they both release acetylcholine. So both the sympathetic division and the parasympathetic division will release acetylcholine from their preganglionic neurons. So this is these are both preganglionic neurons. Then the postganglionic neuron will release acetylcholine as well. So both the preganglionic neurons and the postganglionic neurons in the parasympathetic division release acetylcholine, which means that they're all cholinergic because they're releasing acetylcholine. The other thing is that the postganglionic neurons in the parasympathetic division are short. Most of the time, they're either on the effector or very, very close to the effector. The effectors for the parasympathetic division are going to be the cardiac muscle, smooth muscle, adipose tissue, and glands. Some effectors that do not have sympathetic stimulation and only have sympathetic stimulation are the sweat glands and the erector pili muscles and the peripheral blood vessels. So again, these are sympathetic only. If we think about the response of the parasympathetic nervous system, this is our rest and digest nervous system. So think about everything that's going to occur when you're resting and digesting. So some common effectors are the pupil constrictor muscles. So the pupil constrictor muscles will be stimulated, they'll contract, and a person will have pupil constriction. The heart. If the parasympathetic nervous system is stimulated, the heart will decrease in heart rate and decrease in contractility, so it'll slow down. Heart rate slows down, the strength of the contraction slows down. So the heart will be inhibited. And then the lungs. The lungs will be inhibited too, and there will be decreased diameter of the airways. So there will be less air coming into the lungs. When you're resting and digesting, like just after a big meal, you think about getting all sleepy and your eyes become constricted and your breathing rate slows down and your heart rate slows down. And then we think of things like the GI tract. And in the GI tract, we have increased saliva production, so increased salivation because you're trying to digest food, and saliva has digestive properties. And you get increased mucus production in the GI tract. And you get increased motility in the GI tract. You think about the urinary system, and you'll have an increase in urine production and an increase in urination. So to get that, you have a relaxation of the sphincter muscles. The other thing you have in the GI tract is an increase in defecation. So you have relaxation there as well of the sphincters. Adipose tissue will be inhibited. The breakdown of triglycerides will be inhibited because you don't want to, when you're resting and digesting, you want to store nutrients. You don't want to use nutrients for energy. With the parasympathetic nervous system, there are two different types of receptors. One is called a muscarinic receptor, and those are basically on all of the effectors. So all those effectors have muscarinic receptors on them. And then there is a nicotinic receptor. And the nicotinic receptors are basically found on the cell bodies of the postganglionic neurons. So when acetylcholine binds to that receptor, it stimulates the postganglionic neuron and and then that causes action potentials to travel down the postganglionic neuron. We also find nicotinic receptors in the somatic nervous system at the neuromuscular junction. So in the somatic nervous system here, when acetylcholine is released and it binds to that skeletal muscle receptor is nicotinic. All right, so we do find nicotinic receptors in the somatic nervous system. All right, so we'll go back down to our parasympathetic division. So the postganglionic neuron is releasing acetylcholine. Acetylcholine is going to bind to each one of these receptors and will either stimulate it or inhibit it. When it binds to the cardiac muscle, it will inhibit it, so you slow down your heart rate and slow down the contractility. When the parasympathetic division is stimulated and acetylcholine binds to smooth muscle, like in the GI tract, it will cause an increase in, it'll be stimulatory, and it'll cause an increase in contraction of those smooth muscles. So we get increased motility of the GI tract, increased motility in the urinary tract. It will inhibit adipose tissue so that adipose tissue does not release triglycerides to be used as energy, and it will stimulate glands. So basically, when the parasympathetic division gets stimulated, it's going to increase all of the secretions in your body. So it's going to increase the secretions of the lacrimal glands, so tear production increases. It increases the secretions of salivary glands, so saliva is produced, increases mucus production in the GI tract and the urinary tract and the reproductive tract. So it causes a lot of secretions. If the sympathetic nervous system is ever overstimulated, we get what's called sludge. And this is where there's an over secretion of all of these secretions. So S stands for saliva, so we get increased salivary production. L stands for lacrimal, so we get increased tear production. U stands for urinary, so there's an increase in urinary function, so more urine is being produced. Think of urine as like a secretion. D stands for defecation, so there will be increased defecation or possibly even diarrhea from all of the increased mucus that's being produced. G stands for GI distress, so the GI tract will be increasing motility and there will be a lot of cramping and pain involved with that. And E stands for emesis, which is vomiting. So there will be an increase in vomiting because of the increased motility of the stomach and the GI tract. Then the last thing I want to point out is that dual innervation occurs with the autonomic nervous system. And what dual innervation basically means is that many of the organs in your body are innervated by both the parasympathetic nervous system and the sympathetic nervous system. There's a few exceptions like we talked about, so except for sweat glands, those are only innervated by the sympathetic nervous system. The erector pili muscles, as well as peripheral blood vessels. Those are all stimulated only by the sympathetic nervous system. Dual innervation, that means when the parasympathetic nervous system is working, the sympathetic nervous system will be resting. And when the parasympathetic nervous system is resting, the sympathetic nervous system will be working. So now let's look at some possible drug interactions. So now we'll look at drugs. Drugs can either be agonists, and if they're an agonist, they will activate a receptor to produce a biological response. So they will activate a receptor. And then there's antagonists. An antagonist will inhibit or block a receptor. An agonist in the sympathetic nervous system is sometimes called a sympathomimetic drug. Sympatho means sympathetic nervous system. Mimetic means to mimic the nervous system. So that will activate a receptor. An antagonist of the sympathetic nervous system drug would be known as a sympatholytic drug. And so a sympatholytic drug would block the receptor. So if we go back up and we look at our sympathetic nervous system, here's our sympathetic nervous system. So an agonist would activate any of these receptors. It would activate the alpha-1 receptor, the alpha-2 receptor, the beta-1 or the beta-2 receptor. So it activates them. By activating them, they'll be able to do their job. So an alpha-1 agonist would dilate the pupils and constrict the peripheral blood vessels to raise blood pressure. An alpha-2 agonist would inhibit the release of norepinephrine, which would then inhibit all of the responses of the sympathetic nervous system. A beta-1 agonist would activate the beta-1 receptor. So it would increase the heart rate and increase the contractility of the heart. And a beta-2 agonist would inhibit the contraction of the smooth muscles in the airways, so the airways would dilate. That's what an agonist would do. Some agonist drugs are not that specific. So maybe the agonist is just an alpha agonist. If it's an alpha agonist drug, then it's going to activate both the alpha-1 and the alpha-2 receptors. Or if it's a beta agonist, then it will activate both the beta-1 and the beta-2 receptors. Sometimes it's important to be very specific, because if a beta agonist were given to a patient that had already had hypertension, and we did it in order for them to breathe better, say they had an asthma and we wanted to give them a beta agonist, and we gave them a beta agonist which helps them to dilate their airways, but if they also already had cardiovascular disease with high blood pressure, we wouldn't want to increase their heart rate and their contractility, because that would just aggravate their high blood pressure. A sympathetic antagonist would block these receptors. So if it blocked alpha-1, then the pupils would not dilate and the blood vessels would not constrict. And so it would cause the pupils more or less to constrict, and it would cause the peripheral blood vessels more or less to dilate. A sympathetic antagonist would block alpha-2 so that more norepinephrine would spill out, which would activate all of these effectors. A beta-1 antagonist would block beta-1 receptors, and so there would be a decrease in heart rate and a decrease in contractility. And a beta-2 antagonist would block the beta-2 receptors so that the airways would not really constrict, but they would go down to their most narrow diameter that they could. And if we look at the parasympathetic division, if a patient was given a muscarinic agonist, then all of the muscarinic receptors would be activated. So the heart rate would go down as well as the contractility. The adipose tissue would not release triglycerides. The smooth muscles of the digestive tract, urinary tract, and reproductive tract would contract, and the glands would start secreting all their secretions. If a patient was given a muscarinic antagonist, then these receptors would be blocked. So then the heart rate would go back up, the smooth muscles would be inhibited, and so motility would slow down, urinary production would slow down, and the reproductive system would slow down. The adipose tissue would start releasing triglycerides. The glands would stop secreting all their secretions. So that's how I would like you to think about agonists and antagonists. Because when you get to a pharmacology class, you're going to be looking at agonist drugs and antagonists. And again, a sympathetic agonist is known as a sympathomimetic drug, whereas an antagonist is known as a sympatholytic drug. And with a parasympathetic nervous system, the parasympathetic agonist is known as a parasympathomimetic drug, and the antagonist would be known as a parasympatholytic drug. This ends this review on the autonomic nervous system. I hope it was helpful.